Presenter Dr. Meghana. Panelists Dr. Girish Gupte, Ujjal Poddar, Dr. Pravin Rathi. And the topic is Hepatomegaly, Diarrhea and Failure to Thrive, Lesson of a Lifetime. May I have on stage the panelists, please? Dr. Girish Gupte, Dr. Ujjal Poddar, Dr. Pravin Rathi.
Well, I think before we start, we as organizers had thought that to make us learn, the best way is we must make mistakes. And unless we make mistakes, we will not learn. So we are very keen that moderators and panelists should never know the cases. Otherwise, we drive our thinking in a knowledge which is already existing. But that's not the way we want to learn. So we decided that the case that's going to be presented has been managed jointly by me and Abba, and therefore both of us should not moderate this. I request any one of you three who are a pediatric gastroenterologist to come and come, Sima, come and moderate, please. Yeah, it will be interesting because all of us will learn better how a person who doesn't know takes us the lead of examining. Thank you very much for doing that. Please come.
Thank you, Dr. Amdekar, because it was looking like an MD exam for me, this case. Dr. Amdekar on the other side of the table, we on this side of the table.
You can breathe easy now.
Okay, I'm going to present a case who had with hepatomegaly.
I'm not comfortable.
Yeah, right. May I start?
Yeah.
So, we had this, I'll just skip all this. We had this 14-month-old child who presented to us with history of loss of appetite and failure to gain weight for 5 months, duration of 5 months. A month later, the mother noticed that she had gradually progressive abdominal distension, and another month later, she started having increased frequency of loose, greasy stools. This was the history. On direct questioning, the mother said that there was low-grade fever off and on, but it was not a very significant complaint. However, there were 2 episodes of significant fever in the past 5 months. They were treated as malaria and typhoid fever empirically. There was no objective evidence in the form of any reports. There was no history of any abdominal pain, though difficult to discern in a 14-month-old. There was no history of any vomiting. There was no history of jaundice or high-colored urine. There was no history of any swelling over the body or any pallor noticed by the parents. Growth and development up till around 9 months of age when the complaint started were absolutely normal. Birth history and family history were not contributory. The child was vaccinated for age.
Wait. Just go back.
Yeah, you go back one slide.
So this is a child who comes to us with failure to thrive, gradually progressing abdominal distension, with steatorrhea possibly. And on direct questioning, we do get history of fever off and on. And at least 2 episodes of fever that you've mentioned in the next slide have been there, for which she was empirically treated, and it subsided after that.
Yes.
There's been no history of any other, no jaundice, no edema, no pallor. Prior to this, the failure to thrive was not there.
Yes, so up to 9 months of age, she had grown well. The mother, in fact, recalled the weight.
No contributory family history or birth history, and the immunization up to date is okay. BCG uptake was there?
Yes, on examination there was a BCG.
BCG scar present?
Yes, on examination, yes.
Okay.
Should I give you the examination?
Just wait. Would you...
Can you qualify the diarrhea part? That what do you mean by loose, greasy stool?
So she said that there was this increased frequency of dark green colored stools, and they were very, she actually said tail jaisa. So it was greasy.
Steatorrhea.
Yes.
Steatorrhea. Failure to thrive, possibly there's abdominal distension, maybe organomegaly with steatorrhea. Okay, go ahead.
Should I analyze the history or shall we go ahead?
Yeah.
Right. So when we go back to the first month of illness, there's this child who has loss of appetite and she's not gaining weight. With this, what are the clues that we get? What can we think of?
Can you give us one answer? What age is this first month? How old is she?
She is 10 months old.
Okay.
10, 11 months old, yes. So this is the only clue we get at the end of the first month of illness was that this is an evolving disease. Now, an evolving disease in a 10-month-old with loss of appetite, not gaining weight, could be a chronic non-localizing infection. It can be anything from a partially treated infection because of those history of intermittent fever.
Girl child.
It can be or a non-infective disease completely. So we're actually nowhere at the end of the first month of history. Now, when we come to the second month, we had our first clue to localization. That was in the form of the gradually progressive abdominal distension.
Okay. Now, so this gradually increasing abdominal distension, what do you think of? What could it be? The various F. So one, it could be fluid inside. Second, it could be organomegaly. Okay.
So it could be an ascites, or it could be any organomegaly in the form of a localized mass, or an hepatosplenomegaly, if we characterize the organomegaly. Right. So what about ascites? Does this sound like ascites? Gradually progressive abdominal distension evolving over 5 months.
Yeah. So do you think it is, which of these three is it favoring most, this diagnosis, this history?
No, if you qualify your statement further, it is not difficult to decide whether it is ascites or organomegaly. You describe it. Is it a generalized distension? Was it associated oliguria, or is it other features of hyperproteinemia?
Oliguria.
Obviously, you will go by ascites. Or the patient has received some drug with which there is a diuresis. Or if it is a localized, mainly the upper part of the abdomen, you think about hepatosplenomegaly, or center of the abdomen, not generalized. Obviously, you think about some mass. So you need this information to say whether ascites or this is organomegaly. Just abdominal distension doesn't mean anything.
So actually, the mother says that the abdominal distension was more noticeable after giving meals, and it was in the upper part more prominently, right? So from there we are
upper part.
Again, you are confusing. Don't confuse the audience. They are learned audience. After meal doesn't mean organomegaly.
Yes.
That indicates the bowel.
Yes.
Yeah.
And then you were telling mainly upper part. So if there is a bowel distension, it will not localize to the upper part. Upper part means it is a hepatosplenomegaly.
So she was saying it's the upper part of the abdomen.
And largely after eating meals.
She noticed increased distension after meals, and she had loose greasy stools.
Okay.
So if we analyze that on history, supposing we consider a hepatosplenomegaly, this could be what is the causes of this hepatomegaly? It could be hepatocyte, biliary tract, RE cell, or venous involvement. All causes of the hepatomegaly.
Yeah.
Should I go ahead with the analysis, or would you like more questions?
No, yeah. So at this point, if you try to see,
yeah, I'll not show that.
you give
now.
those four options.
Yes.
Okay. So you give. There's been no jaundice at all. So which among these 4 things that he's talking about should practically be cut off or ruled out? She says there's no jaundice throughout. So biliary tract is one thing which is less likely to be involved. So what next? What about you?
I think I think she's already put up the slides.
Yeah.
So it's a little bit difficult to go back on it. But one of the clues over there was your history of infection. History of repeated infections. And the other thing was the relevant question that Dr. Alam asked was about the BCG scar, whether it was taken up or not. So
Yeah.
those in addition to the other things, those are the pointers, towards what this could go to the diagnosis, as I understand what it could be. Because, this is abdominal distension, this is unlikely to be ascites because it's upper and it's not generalized. And there is a history of
Fever off and on.
Fever off and on, and that also repeated episodes of fever, which again need to be teased a little bit more because, 14-month-old girl, if you are staying in the West, you have winter all the time. So you can have recurrent episodes of upper respiratory tract infection. So I think that needs to be teased out a little bit regarding the fever history as to, what exactly the infections were, how they were treated, and you know, how unwell was the child, unwell with those infections. So those things need to be teased out a little bit more in that.
So she had those episodes at 10 months of age and 12 months of age respectively. Both of them had, during both times she had high-grade fever spikes lasting around 3 days, which subsided with antimalarials in the first occasion. In the second occasion, I think she had received oral cefpodoxim for 5 days, and she subsided with that. She was not sick, she did not need admission, she was taking orally during that time, she was well between fever spikes.
But in total, there have been 5 episodes or 4 episodes.
No, there's been just 2 episodes.
2
Two
episodes.
episodes.
Okay,
Okay.
only 2 episodes. Okay.
And no episodes before that.
No,
No.
absolutely fine.
Okay.
About the loose stools, can you little elaborate what kind of diarrhea it was? Was it a large volume,
Upper
small
bowel.
volume, associated with oil droplets? Was there associated abdominal pain?
She
Like
was
the diarrhea was pancreatic or small bowel, like, on history?
right. So she said that it was bulky, it was oily, and I mean I'm translating. It was bulky, it was oily, it was greenish in color. We directly asked her, does it stick to the pan, does it flow from the pan? So she had not noticed all that. The child was in the diaper most of the time. And yes, sir.
So all we know is that there were oily stools and
Yes.
possibly there was steatorrhea going on.
Yes.
Okay. So without jaundice, one thing is ruled out most likely is, as we go like this, I mean, I do not know why we're doing the analysis without having the complete investigation, complete
Should I go
examination.
again to the
We
examination?
don't even have the examination, yeah.
All right. Right. So
Yeah.
on physical examination, this child looked chronically ill. She, the vitals were stable. She was afebrile. Her growth-wise, she was length of 70 centimeters and
Go back, yeah.
a weight of 7.8 kgs at 14 months of age. So there was some problem there. She was falling below the 10th centile. Head circumference was 45 centimeters. She was malnourished. There was mild pallor. There was no jaundice, edema, or skin rash or lymphadenopathy. The eyes, bones, and joint examination, everything was normal. On systemic examination, liver was palpable, 4 centimeters below the right costal margin, with a span of 7 centimeters. It was firm in consistency with a sharp edge. It was non-tender. The left lobe was enlarged and it was firm. The spleen tip was palpable. There was no ascites or there was no free fluid. There were no engorged veins over the abdomen or over the neck. And rest of the systemic examination was normal, barring a slightly irritable child.
Lymphadenopathy, peripheral lymphadenopathy?
No.
No, there wasn't any lymphadenopathy, sir.
Can you sum up your physical findings, complete findings here?
Right, so in summary, we have this 14-month-old child with history of on and off fever with probably intestine features of malabsorption with a gradually progressive abdominal distension, which is a hepatomegaly with mild splenomegaly, and that's it.
And
With
he's
failure to
severely
thrive.
malnourished.
With failure to thrive. Yes.
I
Yeah.
know you're supposed to ask us questions, but can I ask the presenter a
Yeah,
question?
Yes, sir.
please.
No engorged veins over the neck.
Yeah.
You know, what were you thinking about, just for my education?
Right, sir.
Abdomen.
No, she said
neck also.
Neck.
The abdomen I can
Yeah.
understand. But the neck is something I'm struggling, because I've done my MD a long time ago now.
So there's this child with hepatomegaly, and in one of our seniors' experience, there has been a child who presented with isolated hepatomegaly as a manifestation of right-sided heart failure in a case of pericarditis. And in that child, the neck veins were engorged. So isolated
I think that's what you're doing, what you're trying to look for is the jugular venous
jugular
pressure.
venous
Yeah.
pressure.
But okay, so sorry, my understanding of engorged veins is a bit different.
No.
Yeah.
So I'm sorry.
The JVP was normal, that's what
Yeah.
we wanted to say.
Okay.
Right.
So this is, yes, sir. So let me get back to the case a little, because this is the first time yeah.
Time,
Yeah.
when you have got hepatomegaly, splenomegaly,
Yeah.
you have recurrent episodes of fever.
Severe
What will
malnutrition.
be that's fine. What will be the DD in this patient?
So if you,
Related to hepatobiliary system.
and with 4 episodes of fever,
Fine. We
2
are saying
episodes of,
recurrent episodes of fever, responding to antibiotic therapy or whatever. What will be the DD?
I would think of an infiltrative,
Now, why not a biliary tract problem like coronal cyst, like cystic disease of the liver, where there may be a pardon? Now, No, only one episode.
He's
of
has
diarrhea.
no. She's been having oily stools for past. So there's diarrhea, there's fever, there's hepatosplenomegaly, there's severe malnutrition.
Right. So, what other DD could be there? Any patient with hepatosplenomegaly, recurrent episodes of fever, and
Yeah,
melanoma?
I was thinking of primary immunodeficiencies. We should think of
Cystic fibrosis is the cause. Cystic fibrosis.
cystic fibrosis. 9-month-old cystic fibrosis is another possibility that.
Another DD here, so we have to analyze this way.
However, the
Cystic fibrosis in
Just 2 episodes.
presents primarily as a respiratory.
Yeah,
The diarrhea is silent,
I will.
and diarrhea has to be picked up.
Yeah.
Failure to thrive and a respiratory problem. I think while liver disease may be a cystic fibrosis, that's rare.
Very rare.
My CF comes
See,
as a respiratory.
liver disease and cystic fibrosis will come in the second decade.
No, it's not that. See, if you look at, I'm not touching on cystic
Yeah,
fibrosis,
yeah.
but if you see as a cystic fibrosis presentation, respiratory fine, GI isolated or combined.
Yeah.
So if we look at Dr. Kabra's series from India, who has described a lot of cystic fibrosis, most of them are having actually respiratory problems. GI
Yeah.
so far he has not shown GI cases with respiratory involvement, he has not shown. I'm not making the diagnosis.
Okay.
I think one should keep it in mind, although the presentation is there, what Dr. Ambedkar sir is saying. That is fine, we agree on that.
Okay. I have done nothing, not even seen the patient, but anyway, we'll ask.
we have done. It's coming up now.
Other possibility probably would be histiocytosis, what Dr. Poddar was hinting
Yeah,
at.
I was saying
Is there any lymphadenopathy or not? He's asking.
infiltrative, yes.
Yeah.
We should think of. Volman's, but this is a 8 or 9 months old, and Volman's usually don't survive this long. And
renal
it's
manifestations
CESD, and they have usually hepatomegaly alone.
This one isn't too big of a liver. Liver span is 7 centimeters. So
Just a
about-
marginally increased
yeah,
liver,
just-
it's more of,
just about. I would
and
be
spleen
more-
is also just 10
just
palpable.
I'd be more concerned to say that the liver is firm.
And
rather
left
than
lobe
the
is enlarged.
liver.
Yeah.
Systemic causes, you have to consider, like, let us say this child has HIV infection.
Yeah.
That could present with hepatosplenomegaly, that could present with recurrent source of fever, opportunistic
So
infection.
that's why I would say immunodeficiencies and infiltrative disorders will be my, I would put my coin, or bet on that.
Yes. Should I proceed to the investigations?
Yeah.
So we don't have any role to play.
Right. So on day 1 of investigations, her hemoglobin was 9.7 on admission. There was some anemia. The total counts were 28,200 with polymorphs of 52%. Platelets were normal. It was 5.2 lakhs. CRP was 15, which was mildly elevated. The AST was 120. The ALT was 88. And the total protein was 8.5 for an albumin of 4.6. Alkaline phosphatase was 2060. And GGTP was 851 with a bilirubin of 1 and a direct component of 0.4. LDH was elevated, it was 1850, and the uric acid was 2.3. So we've considered infection here. So there is a neutrophilic leukocytosis. There's a mildly elevated CRP. Coming to any hepatobiliary disease, the alkaline phosphatase is elevated, the gamma glutamyl transmembrane is elevated. There's a mild direct bilirubinemia. It's more than 20% of the total. And there is a possibility of malignancy which we considered. The LDH is elevated significantly. There is an increased cell turnover happening somewhere. And
Yeah. CGD is.
Still merit consideration here.
yes,
This child.
yes, sir.
High gamma GT, high alkaline phosphatase, LDH positive.
Infiltrative is the definitely a
AST
stronger
will be mildly
possibility.
elevated.
Yeah. But
The-
with this tooth,
Malignancy with infiltrative deposits because of leukemia, lymphoma
Yes.
also.
yeah.
So we've covered all those points here. What next? What would you like
But
to do next?
how would you explain the total leukocyte count? I would ask you. Do you have? How would you connect the two of them together?
She has already connected them.
There's
Infection,
mild infection or
inflammation.
inflammation. Yes.
So I cannot connect anymore. So but I think sorry. No, okay. No, I think clearly, if you interpret the liver function test, this points towards not a primary liver problem, but towards a secondary liver, where the liver has been secondarily involved. And the fact that the LDH is high itself is a pointer towards the secondary liver problem or some necrosis of the cells that is happening somewhere else rather than the liver itself. And the white cell count high suggests, with the past history of these couple of episodes of infection, which are very questionable, suggests that there may be a problem with the immune system that you may be dealing with over here, or there may be a problem of, this may be just a secondary infection that you may be dealing with over here. But the CRP is not particularly that elevated, which I think slightly goes against that part that the infection, systemic infection is an overwhelming infection. There is infection there.
She was a well
but it's
child.
not an overwhelming infection.
She was a clinically stable child.
Sorry,
and she
you
was
said
not.
the child looked sick.
She looked sick, but then she did not merit IV fluids and no, sir.
So what Girish has said, I will sum up with that there is an infiltration into the liver.
Yeah, yes.
Hepatocyte dysfunction is not much, but alphas gamma GT elevation suggests there is an infiltration, which is causing micro level biliary obstruction, not overt. That's all. So we don't know what infiltrative disease is.
Yes, sir.
So next investigation, if you ask, we need imaging.
You want an ultrasound, sir?
Depends.
We have to remember that infiltrative disease
Ultrasound
at
and
what
chest
age?
X-ray. Okay.
No, shouldn't we go forward and just think of some possibilities under the infiltrative diseases, keeping the age of the child in mind and the whole presentation in mind? Okay.
Right, an ultrasonography was done which showed multiple hypoechoic lesions diffuse with increased ecotexture of the liver, suggestive of multiple cholangitic abscesses. The chest X-ray was normal, sir, and a skeletal survey clinical was normal.
Ultrasound showed mild abscesses, cholangitic abscesses.
They labeled it cholangitic abscesses, and there were multiple hypoechoic lesions on the sonography. Diffuse.
Sure, on ultrasound you can say cholangitic.
You can.
Yeah.
In a 1-year-old child?
No, you can.
Multiple?
I think, I agree.
You can.
Your ultrasonographer is mixing histopathology with radiology over here. I am really sorry to say.
But she's
because
calling
cholangitic is a histopathological diagnosis. And they may say that,
Cholangular abscesses.
these are, you cannot localize them to the biliary system. I know we are entering into a discussion that we don't need to, but I would just like to say that these are probably abscesses. I support that. But the cholangitic part, I would not support.
With due respect, sir, the cuffing of the biliary tract, intrahepatic biliary radicals, if there's a cuff around them, the sonologist can say that there is something called periportitis, and that she interpreted it as a multiple cholangitic abscesses. And
cholangular abscesses, maybe.
Yes, she was not wrong in calling them that.
No. To level a cholangiolytic abscess, you have to show the communication between this abscess and biliary system.
There was communication, yes,
So
sir.
was there intrahepatic biliary radical dilatation, CBD obstruction with dilated CBD on ultrasound?
There was no dilated CBD. There was mild intrahepatic biliary radical dilatation, but not at this stage, at a later stage, sir. Okay. We had to review the ultrasound because this did not lead us anywhere.
We like this radiologist. He can look into the future.
Okay, so
Probably retrospectively looked at.
Yeah, that's right. That's what I'm trying to say.
Yeah.
That's what I'm trying to say, that you cannot, yeah.
okay.
No, sir.
No. So then you did what?
Considering an infection, giving the benefit of doubt, we started her on antibiotics. However, we worked her up further. Blood culture was negative, and HIV and other viral markers were negative. Serum immunoglobulin levels and a lymphocyte subset analysis and an NBT were all normal, so we ruled out immunodeficiency primary. Bone marrow was done because in consideration of when we looked up the differential diagnosis of multiple hypoechoic lesions in the liver, one of the differentials was disseminated or metastasized leukemia or lymphoma, and in view of elevated LDH, we did a bone marrow directly, which was a normal morphology. Alpha fetoprotein and beta HCG were normal, considering primary liver malignancies. After 14 days of antibiotic therapy and supportive care, the child had no clinical improvement. There was occasional fever, and there was further weight loss documented. And a repeat sonography showed that the abscesses were of the same size as before, and they had not regressed. Hemoglobin had dropped to 9. Hemoglobin lingered at 9. Total count was 23,000. Platelet count was still normal, 5.3 lakhs. CRP was 22. SGOT, SGPT almost the same. ALK-phos and GGTP still elevated. Mild increase in the bilirubin with again a direct component but no clinical jaundice. LDH still elevated. Right. Antibiotics were changed to second line and given for further 14 days. And over the next 14 days,
sorry, can I interrupt over here?
Yes, sir.
So we've got an abscess which is not responsive to treatment over here. So I don't know, but I will not wait for probably 14 days. This child had temperature for 14 days, isn't it?
sir, she had intermittent spikes but not daily spikes. No.
Not daily.
We've not
No.
tried
On and off 99.
a drain,
Yeah,
There were multiple small abscesses, and
tap. Okay.
the stool pattern normalized over the next 14 days. The fever spikes were present on and off. There was a weight loss. Activity was poor. The child was still unhappy. There was progressive enlargement of the spleen, but the liver remained the same size. However, she did not develop any new ascites. There were no engorged veins and no clinical icterus.
Go back.
Yes, sir.
Yeah.
Yes. So during these 14 days, we worked her up further during this.
Liver histology.
Yes, sir. We have done a histopathological examination.
No.
Right. The spleen had no lesions on sonography. Now, before we went ahead and did the liver biopsy, the considerations were: should we hit the lesion? Should we hit around the lesion? Diffuse disease. We took the pediatric surgeons into consult. We took the hepatologist into consult, and they said that it's better to do an MRCP. The MRCP was suggestive of sclerosing cholangitis or congenital hepatic fibrosis. There were few intrahepatic biliary radicals which were dilated. All of them were communicating with the main duct, and there was a hepatomegaly. This is what the MRCP told us. And based on this, they said that it's better to do an open liver biopsy with an intraop cholangiogram.
How did you see?
Sorry.
The point is, I think that you should respond.
Yeah.
No.
On MRCP, how are you going to make congenital hepatic fibrosis?
Sclerosing cholangitis, okay, but how do you, what?
Sclerosing cholangitis, again,
Yeah.
in such a situation,
Small,
where
it's very
you have
difficult.
abscesses around, or microabscesses, what you say, to give diagnosis of sclerosing cholangitis should be a little difficult.
Yes,
I
sir.
think
Probably they have said it is a Caroli's disease or Caroli's syndrome with multiple
Infection.
abscesses
underlying
with dilated duct and
Yes.
Secondary
underlying
infection.
congenital hepatic fibrosis.
So an intraop cholangiogram was done with the liver biopsy.
I am sorry, but what I don't know how nicely to say it, so I won't say it nicely. But I will not go for an open procedure on this child. That's one. Second is, I think a liver biopsy itself would be sufficient for an ultrasound guided liver
yeah.
biopsy, so that you are not targeting any
Yeah.
lesions, you're not disrupting the biliary system, would be sufficient to would be a sufficient step forward, to reach the diagnosis. And you can then decide at the time of the ultrasound, because if you have an experienced sonographer, which you do have within your department, that whether you can tap one of those
Abscesses
no,
at the same time.
at the same time to get some material, because you've got a resistant infection. So I think an open might be a step too far, but that depends on the situation at that time and the child at that time. I recognize that, but I will just say that now that the radiologists are so good, you can get all of these things done with the least minimal invasive procedures.
Okay. So, however, we went ahead with an open biopsy, and intraop cholangiogram was done, and which was suggestive of gross nodules on liver surface, and there was flaky purulent material drained from the lesions, the cultures of which were sterile. It was all suggestive of Caroli's disease intraoperatively, according to the surgeon. and we got a histopathology of the biopsy which was suggestive of Carley's disease. There was intrahepatic.
What is the
What-
biopsy of Caroli's disease?
I know.
There's multiple dilated intrahepatic biliary
No,
radicals.
biopsy. You are talking about liver biopsy. That will not show what? That will not show dilated biliary system. That will show something. You are looking at the microscope, under the microscope.
IOC, what IOC has, any comment on the intrahepatic radicals on IOC? You send an intraoperative cholangiogram.
Yes, sir.
One is you are looking at the extrahepatic ductal system, another is the intrahepatic system.
So
What
do you
is
have
the
a
comment
photograph
on
of that? Do you have a photograph?
That might
The
be
intraoperative no,
helpful
ma'am.
in Caroli's rather than biopsies.
Yeah.
Biopsy probably showed congenital hepatic fibrosis, not the
Yeah.
Caroli's disease. And your Caroli's disease is diagnosed on imaging by intraoperative cholangiogram.
But the histopath report also read that.
No,
sir,
they
there's
cannot
small
write Caroli's
intrahepatic
disease.
biliary
They have,
radical tissues.
And
they said the congenital
and what
hepatic
about
fibrosis.
what about the kidneys? When you did the imaging, kidneys.
The kidneys were normal, ma'am. There was no increased echotexture
Okay.
or cysts. Right. So this was a very confusing clinical picture overall. One was saying congenital hepatic fibrosis, one was saying Caroli's disease. However, we were not convinced with the diagnosis of Caroli's disease. And we had a review of the above diagnosis. We sent the MRCP for review because, like you said, Caroli's disease or anything of that sort should have been picked up on the MRCP itself. And so we sent the MRCP for a review. On that, an experienced hepatologist picked up that there is beading, that the biliary radicals are looking beaded, which is suggestive of a process like sclerosing cholangitis. And we looked up the DDs of sclerosing cholangitis in a 14-month-old, which came up to, it's either a primary sclerosing cholangitis, which was not the case, or it could be secondary. With all the periportitis going on there. So,
Somebody wants to comment from the audience.
What could be the causes of secondary sclerosing cholangitis?
yes.
Caroli's disease.
It could be a suggestive of Caroli's disease.
Yes.
And it's a ductal plate malformation.
Here?
Yeah,
You
the upper
go
one.
up,
Upper
top
one,
of that,
up
top
above
of
The
that.
upper one. The upper one. Up.
This
Yeah,
one?
yeah, this one.
Yeah.
Okay.
Yeah, ductal plate
Right.
malformation.
So the okay.
Yeah.
However, the MRCP did not suggest the thing. So
This
This is
is
MRCP.
You have to understand, you are doing MRCP in a situation where there is an infection going on in the liver.
Yeah.
That is the point.
yes, sir.
So, if we are, rather than making it very complicated case, if the approach can be very simple as we said in the beginning, whenever you get hepatosplenomegaly, you have got recurrent episodes of fever, first target your liver.
Yes, sir.
Yeah.
And there might be actually Caroli's disease, ultrasound cannot pick up. Right? So that is how it is looked. You may need a cholangiographic actually picture to diagnose Caroli's. It's not easy in young babies to diagnose Caroli's disease unless you go for ERCP and that will give you the delineation in there. So there is no confusion actually. Confusion has been created by the algorithm which we have done.
Yeah. What about you haven't shown us a liver biopsy? Since
So the liver biopsy was just suggestive of those cholangitic abscesses with periportitis and intrahepatic biliary ductal proliferation. There was a review histopath which was asked in view of this bleeding on imaging, which was picked up, and with this cuffing of the biliary tract. And the differential diagnosis of this is very few. Like you said, secondary cholangitis, sclerosing cholangitis in children, the causes are histiocytosis syndromes. It could be due to HIV or cryptosporidiosis. It could be secondary infiltration from leukemia, the same three diagnoses which we had at the end of history. The slides were reviewed and special staining was done in view of this new angle to characterize this reticuloendothelial infiltration, which stained positive for CD1A and S100, and it was suggestive of Langerhans cell histiocytosis, like we had said. Yes.
And only take Caroli's disease into consideration.
Yeah.
Your alpha, gamma, it is sky high.
Yes, sir.
That is the situation when you have to think of this histiocytosis and sclerosing cholangitis as a secondary part of it. We were just discussing, Vinita and myself, that this is nothing but actually
Langerhans.
histiocytosis is secondary sclerosing cholangitis.
Yes.
So did you do a bone marrow?
The
Did you
bone
do a
marrow was not involved, ma'am.
The bone marrow, she said it is normal.
Normal.
So review after review, third review, we
Yes.
get the diagnosis.
Yes.
And same thing happened with a couple of cases.
Yes,
On
sir.
review only we could diagnose Gaucher's or some other disease.
Only when we asked the histopathologist from this angle of Langerhans cell did they stain for the CD1 and the S100. Prior to that, they could not pick up the histiocytes, the cleaved cells, etc. And in review, she pointed out that yes, there are these cleaved cells suggestive of histiocytosis.
So I think what you are giving the message is a very clear message that you have to ask the right question for the whatever investigation you ask for.
Yes.
Because if you don't ask the right question, then the answer may be very vague.
Right.
What was your order of investigation? First the biopsy.
I think
Yes, so first we did, yes.
What?
So like on day 1 of admission, I'll tell you how we went about in the clinic. She got admitted to us on day 1. On day 1 we sent the counts, the sepsis screen, etc. Then when we picked up the hepatomegaly, we did this ultrasound abdomen. So we had cholangitic abscesses said on the ultrasound abdomen, and we had a sepsis picture. So we started her on antibiotics, then waited for a response. She did not respond. Repeat counts, etc. were still elevated. Then we did a repeat ultrasound to see if the abscesses are shrinking. Is it something responsive to antibiotics? No, it wasn't. So that's when we started that this has to be an abnormal host or it has to be a malignancy. In the meantime, during the first 14 days, we got all the blood reports, the immunoglobulin levels, the HIV. On day 15-16 of admission, because by then we had consulted the pediatric surgeons that there are these abscesses which are not resolving. Is there any operative intent? Yes, sir. Because we had considered a liver biopsy by day 15. When we did, like we said, we have faced a difficulty. A sonography guided liver biopsy blind would have been okay. But when we consulted the pediatric surgeon and the hepatologist, they were of the opinion that it was better to do an intra-op procedure. And also intraoperatively, if you saw my slide, there were gross nodules on the liver surface, which was going against. So that created the clinical picture of confusion.
I think the point. The problem is the secondary sclerosing cholangitis. The first thing it will start with is actually sclerosing cholangitis, like picture, which would be, there would be, very high bilirubin. And with that, maybe pruritus present. And so that sclerosing cholangitis picture was not there right from the beginning, and that's why maybe I can understand that they have had, they've been just roaming about here and there.
We were mainly...
Can I make one point? Sorry, two things. Firstly, I think the bile duct involvement was very clear from the beginning, from the first set of liver function tests. There was a problem with the bile duct, so it was either infective, obstructive, or something like that. The second thing is I just wanted to enlarge on Girish's point, because I think that's very important. And I've heard it again and again at this meeting, is there was a neurological sign, why didn't you do an MRI? There was a this, why didn't you do that? And I think the important thing when you order an investigation, not only should you order the right investigation based on what you know, but you should know what results you want. So when the result of the investigation comes, you should say, I'm going to do an MRCP. If I see this, I'm going to do that. If I see this, I'm going to do that. So you should actually know what outcome. All you're doing the investigation for is to confirm what you think clinically. It should never be a blind investigation. Let's see what this shows.
See, when we had this picture of biliary obstruction right from the beginning, we did start the child on like management with ursodeoxycholic acid was started. And few days later, the stool became normal in consistency. It became normal by the end of around 10th-12th day of admission. Thereafter, it was normal. So this child, actually, we followed her up very closely. Unfortunately, we lost her in July this year. She presented to us a 1.5 years back. She was awaiting liver transplant. Her LCH had... this was a very rare case of isolated hepatobiliary LCH without any systemic involvement. On presentation, the skeletal survey was normal, and the only part which was involved was the liver. But then we started her on chemotherapy, advised OLT, but 3 months into the illness, she was already risk organ positive single system, but she disseminated to risk organ positive and multi-system. She had a parietal lesion, and then later on the bone marrow got involved.
Still, there was no jaundice at that time.
She got jaundice almost 4 months into the illness. She fooled us till then.
Can I just please state that liver transplantation is not really indicated in, I feel, Langerhans cell histiocytosis. And the reason is that we have burnt our fingers with this. It does recur in the transplanted liver. It does cause infections. So be careful about when you, because they may present as isolated hepatobiliary system abnormalities, but they do go on to have multisystemic disease later on. So I think be careful we should all be careful when we put forward children for liver transplantation. And the diagnosis is really difficult to establish when liver is the only involved organ. So I can understand how you struggle with it, because all of us have struggled with it at some stage or the other.
Yes,
but be careful about recommending liver transplantation, because it does recur and it does cause a lot of opportunistic infections when you use immunosuppression in this children.
Has she been
So bone marrow might be
treated with chemotherapeutic drugs? No medical treatment?
She was treated with chemotherapeutic agents that also led to complications. Later on, 3 months into the treatment, she developed biliary cirrhosis, sir, needing reduction of the dose of vinblastine, which is used in the chemotherapy. Also, since she was multi-system, we put her on methotrexate. Methotrexate was also reduced. And subsequent to that, she developed disseminated disease, sir. So it was very difficult to manage this child.
Yeah. I think the first thing is that, thank you very much, Seema. I was to moderate, but I know the whole case. So also Abha knows. So I thought it is fun in medicine to be wrong. And it's fun in medicine to start thinking when we don't know anything.
Yeah,
and I think that is the fun. Second thing is that when a pediatrician sees this child in the first month, he has no clue. When my super specialist sees at the end of 6 months, it looks as if the whole story is perfect. And how can you miss it? I think this is very important. And it is not. This case was largely presented to see that how multiple specialists, each one in his own way, thinks differently. And I think as we clinicians need to learn how clinical profile does not match with investigation reports, we go back to our own clinical acumen or follow it with the laboratory or the imaging people to again keep on nagging them that there is something else that they need to look at. We rarely do that in clinical medicine. Most of us as physicians think that the laboratory or the imaging knows better than what we can understand, but we can see the patient several times. They see only once and they opine. They are blind, but we seem to be blind that they are blind, and we seem to follow that. And I think this was what I thought henceforth we should have this kind of a discussion where no one knows anything about the case. I felt that it's very unfair to all the delegates who know nothing, who are not experienced, and who are expected to talk in front of those who are well experienced and sometimes even know the case. I feel the fun is being wrong, and we just wanted, I didn't want to moderate because me and Abha went through this systematically. We said something is going wrong, but we didn't know for a long time what was going wrong. Each specialist came and did something, we didn't know why he did, but we knew he confused us more than he helped us. So now we learnt all that, and I thought the purpose of this case has been well brought out. Thank you very much all of you for doing that. Thanks, Seema, once again.